Like I said, it is going to be a recall discussion of the INI-CET July 2021 Public Health Dentistry part. So before we move into this discussion, I just want you guys to know that how important this subject or what kind of importance you need to give for this particular subject in this whole paper. So this whole paper comprises of 200 questions, and we have just around some 10 questions which have been asked from this paper. And this again is like not exact number, something around 10. So which is less than 0.5% of the whole question paper. So public health dentistry is a huge, book, or I can say it's a huge fraternity. So in that, certain parts which you need to know, or which I think are very core or important aspect for this INI-CET is compulsorily or definitely you will have one problem solving questions. That is like calculate the odds or calculate the risk ratios. So solving scenarios. So that is definitely one. So you need to learn about that. And then themes or the days, World Hygiene Day, World Health Day, or when was the anti-cancer day, no tobacco day, and what are the themes, so everything. So the days, the important days, you can fetch it from Soban Peter 6th edition, or any Soban Peter will have. 6th edition is better because it will have an updated information. And then themes, WHO themes, it's given mostly. WHO provides 2 themes for us every year. That is one on health and another is on tobacco. So and all these things are present in the website, which I have given in this presentation as references. You can note it down. And before the exams, you're going to give it up, just recollect it or write it in a paper. And every day, once you can just read it for yourself. Every day morning after brushing, maybe you can just flip through it. Okay. And though PhD has got a lot of chapters, the 2 important chapters where you always get questions is the research and biostatistics and epidemiology or public health. So more concentration is on the public health part, and this paper also has all the questions from this end. And the ones which I have seen over here, given it over here, are the breakthroughs of the questions, which out of the 10. Okay, so this is where you need to concentrate on public health dentistry, if at all you're preparing for any national exams. So let us move to the questions. Yes. So this is one question, that is, which of the following is not very significant in screening pro forma of COVID-19 risk in dental office? Okay, so COVID-19 is right now becoming it's a huge pandemic, and everyone is dealing with it, and there are a lot of pressures and stress from either side. So you can obviously expect such kind of a question in a national exam paper. So what is the key? How do you approach a question? You first need to read the question very, very clearly with a clear head, because each and every word which is being put up has some meaning. So the ones which I marked red is what I would call it as, the key to this question. You know why? Maybe if I could give you the options, it will be useful. So if you look at the options, residence in contaminant zone, history of diabetes, contact with COVID patients in last 14 days, and symptoms of fever, sore throat, or myalgia. So if you look at the options, we know that each and everything is something which is related to COVID, right? Because people with compromised immunity tends to contact this infection, and the others are also important history taking. But like I said, the key over here is which is not a very significant one, right? So which means to say, this is my key. So I need to look into the options. When I look into the options, I will know that history of diabetes. So it's like a kind of a straight question and answer if you have noted this point. So whenever you read a question, read it with a clean head, clear mind, and each word is important. So this is a straight question. And if you have noted, this is not very significant part. Okay, so let's go to the next one. I'm starting from the easy ones and going to the tougher ones. So you can stop me anywhere and let me know if at all you don't understand or you feel that it's been confusing. So this is straight questions and not much of discussion would be required here. So I'm moving to the next one. So the next question. Yes. No Tobacco Day, theme of 2021. So this No Tobacco Day is again yet another important day celebrated by WHO every year. And right from 2010, he has been giving us themes. So what is the purpose of this theme is how the world or the stakeholders of WHO are dealing with this problem. So based on that, he will give us one core theme, and that will be used as by all the nations and all the countries to propagate or to make the information materials. So that's how it goes on, even for a World Health Day as well as No Tobacco Days. So No Tobacco Day is celebrated in 31st May 31st May, right? So just remember that. That's also a very important point. So this year, what was the theme which was proposed? If you look at the options, it's not even confusing. Reduce to quit, dare to quit, and quitters win is what we added on. But the first three were the options which was given by the students. So reduce to quit and dare to quit, that was not there, and commit to quit was only thing. So if you can follow WHO pages in Facebook, Twitter, or anything, you will always have this hashtag themes. So you can, by that way also, you can, remember it. Not necessarily you need to go into the website to understand. Just remember the days when it's celebrated. So No Tobacco Day, 31st May. If you can see the Facebook page or Twitter pages just a week ahead or after a week after during that day, you will know that it is being hashtagged and it could be kind of trending. So why this commit to quit was made? Because if you remember the 2020 theme, it was based on tobacco on lung. Okay. So you all know that tobacco has got a lot of harmful effects, right? And one major organ which it targets smoking tobacco is the lungs. And 2020 saw the pandemic of COVID-19, which was initially, set to target your respiratory function. That's why the concept of commit to quit came, because the smokers are more prone to this pandemic infection. So because of that, WHO thought it is high time we pledge ourselves to commit to quit, so that this harmful substance smoking does not cause any problem to the smokers. And especially during this pandemic period, it is very important that though they have a compromised lung function, the COVID infection should not become a comorbid for them as well. So that's why the concept of commit to quit came into play. Okay, so this is the next question, which again is this little direct question if we had gone through the themes. So these were simple questions which were asked. So the next one, yes. What does scientific paper retraction mean? So this again, for people, the target population for this exam are those who have completed your undergrad, right? So in your undergraduation, if you have been exposed to the concepts of research writing, publication, then this question seems to be a little simple to us, because we would have been exposed to the concept of sending articles to journals. And when you send articles to journals, this term becomes familiar. So retraction. And then again, if you look at this term, it's a very simple English word. What does retraction mean? Very simple English word. Can anyone tell me? Retraction. Even in orthodontics, you would someone is answering the chat. Yeah, excellent. Withdraw. So this is nothing but withdrawing or taking back a scientific paper. So when would this happen? You have selected a journal and you have put into it, right? So why do you want to take it back? What will be the situation which will make you to withdraw it? Mostly if there is any duplication of information, or if the editor or someone feels that you have plagiarized. Plagiarism is nothing but copying someone's work without their permission. Okay, so if you have plagiarized, or if the editor feels there is duplication of data and he feels that the credibility of your article is not good, he will expect you to retract it. Okay, that is from the journal's end. From your end, maybe you have submitted and you're waiting for a long period and there is not much of progress from the journal's end or from the editor's point of view. That time you can retract the paper and submit it to a different journal. So these are the two major, ways or the timelines when you think there will be retraction of a scientific paper. So then again, if you could look at the options, they were very straight and not confusing actually. So the reviewers is asking for a primary data. That is again natural, because the reviewers are people who will look into the credibility of your paper. So your paper will be sent to someone, and it will be a blinded process where they will not know who has done this, and they will checklist, how this is done, whether the study is done in the proper way, and whether the data, the analysis, the way it is being written, the grammar, the English, everything will be checked. So those people are called reviewers. So they obviously have the rights to ask the primary data if they feel that there's something wrong. And the journal asking for publication fee. This again is, there are certain chances where you can actually retract in these cases, but that will happen only if the journal has not priorly informed you about this publication fee. But then again, that becomes an ethical breach. Otherwise, every journal would have put up that this is my acceptance fee, this is my publication fee prior to your submission. But if that is not there in any of your websites, then it becomes an ethical breach where you have got the right to retract. But that happens very, very rarely. Okay, so maybe you can think this one as a confusing or one option which you can choose, but the best over here is withdrawn a published article in a scientific journal. And editors asking about complete study details again is not about anything about retraction. Okay, so the option over here, the best option over here is withdrawing it from a scientific journal, and then that again comes with the word retraction. Okay, so the next question, this was the phrase which we got. It was not actually even a question. So it was about vaccine matching. So we just thought about what could be the possible ways in which we will get an MCQ, or the possible ways in which, you can approach this question. So can anyone tell me what is the first vaccine which is given to anyone at birth? The first vaccine. Yes, I think I can expect some answer in the chat box. No idea. I'm pretty sure all of us will have a mark in our hand, right hand. Yes, I got an answer. Yeah, excellent. Yeah, BCG. So that's the way we remember it. Very good. Yeah, you're right. So at birth, the first vaccine which you give is BCG. Apart from that, you also give hepatitis B. So I just thought you just need to know about the important vaccines. So these at birth and 2 months are the common questions of vaccines which have been asked so far. So at birth, it is BCG and Hep. So the question probably would have been a match the following, where they would have asked like at birth and given some options, and at ages, different ages, what were the vaccines. So that could have been one possible question. So that's how I plan to discuss this answer. So at birth, it could be BCG, hepatitis B, and at 2 months, you have Rota, DPT, and polio drops. So when I talk about polio drops, they are unique. The first thing which strikes as an aspiring NEET MDS or any MDS preparing candidate is pulse polio, right? And all of us have seen that every January, like for past 2 years, every Jan, around after 15th to the end of Jan, you will have seen a lot of orthos calling out saying, for pulse, please come over to put your polio drops. So that is called the pulse polio program. But there is one information which you need to know as a 2021 batch, because this pulse polio vaccine, till 5 years, so far the government said that all the kids needs to have this pulse polio vaccine apart from their regular vaccine programs. But they are planning to stop this by next year in 2022. You know why? Any answers? Okay. You know why? Because we have already been said, we have completely eliminated polio from our end, and we are almost on the verge of eradicating it. Yes, someone is answering. Excellent. We have not actually eradicated it. We are at the verge of eradicating it. We have India is still, yet to be listed as eradicated by WHO. But that will eventually happen by 2022. That's what is expected from the health department. That's why they proposed that this pulse polio will stop by 2022. So probably next year, if this kind of a vaccine question is going to come, which generally comes into the public health area. So if that question comes, So this could be one possible question for you next year as well. So just have these small tidbits in your mind, and you can even note it down in some paper. So let's move to the next question. Yes. Yeah. So an example of a bimodal, or we didn't get a proper question for you. So I just given the possible questions which could have been asked. So example for a bimodal, or which of the following is a bimodal distribution, or it could have been a true or false. Yes, please. Someone has raised their hand. Yes. Am I too fast? You have something to ask, you can drop in the chat box if you have some technical issues. I suppose it was by mistake then. Shall I continue? Yes? No? Yeah. Okay. Thank you. Yeah. So this could have been, maybe it was just an example for bimodal, would be an MCQ, or which of the following has bimodal distribution could be one possible question, or true or false, like Hodgkin's lymphoma is bimodal in nature. Is that whether the statement is true or false? So I almost given up the answer. So I'm going to ask you what could be the possible answers over here. So before that, just a second. Yeah. So I just thought, yeah, so I could tell you what a bimodal distribution is. So I suppose my screen is visible. If not, please raise your hands so that I will know. So this is how a bimodal thing will be. You know, it will have a peak. I'm sorry, I'm bad in drawing. So, yeah, it will have a peak, one peak like this, and one more peak like this. Okay. Yes. So yes. So these two areas are called modes. So what is a mode? Mode is nothing but the highest point in any distribution, right? So a bimodal is something. Bi means two, tri means three. All of us know this, right? So bimodal is two high points. So how do I say that Hodgkin's lymphoma is bimodal? So it means to say that this kind of a disease happens in two age. That is 15 to 24 and more than 60. So this is the age incidence of this Hodgkin's lymphoma. I've seen higher the people from 15 to 24 years as well as more than 65 years. So that's why we call this as a bimodal in nature. And same goes with dental caries. So what are the two age groups you think dental caries is more commonly seen or higher? What could be the possible age groups? Yes. Four to five. What do we call that as? Do we have any specific names for dental caries in younger children? Yes, I go with 4 to 5, but I just want the name. I don't go for acute caries. What is the early childhood caries? Infant caries? Yes, ECC and root caries. Excellent. Yeah, I've got the answer. Thank you, everyone. So yes, it is. Yes, exactly. Yeah, great response. Thank you, guys. So it is ECC and root caries. That's why we say dental caries is also bimodal in nature. So though the option or the answer which was expected in the INI-CET was Hodgkin's lymphoma, but I just thought I would give you this information as well, so that next time when Hodgkin's is not given, but you're given some other option, as a dentist, because MDS is what we are aiming at, right? So dental caries is one oral condition which has bimodal in nature. Okay, so let's go to the next one. Yes, a very, very interesting and favorite topic for any public health dentist. So smoking and lung cancer, these two are like keywords for anyone to ask any number of questions. So can just so this again was a phrase given to us. So I just thought I would discuss this in a possible manner. So my first question is, there's a word called as association, right? So do you think, what are the types? That could be one possible question. That is smoking and lung cancer. What type of association? Yes. Go ahead in your chat box. Come on, everyone. I would like you guys to speak quick because we have one more faculty waiting to discuss the periodontics. So please fast. Okay. So I suppose I give you the answer. So you have direct, indirect, and spurious. So this is something which is there in textbook. So for me to understand the concept so that I can answer the question is direct. These are simple English words, remember, okay? So direct means I need to have a direct hold. Smoking causes lung cancer. I need to have a proof to say it is direct, right? So for that, I would say that it needs to be in a causal pathway. So you mean to say that association and causation are different? Yes, they are different. Okay, so how do I say whether it is a causal or association? So one way is if it is direct, but how do I know it is direct? For me to know it is causal, then I can say it's direct, right? Not the otherwise. So for me to know either it is causal or not, there is something called as Hill's criteria. Okay, so this Hill is a person who has given us some 8 to 9 criteria to say that the relationship between two variables is said to be causal if it has following characteristics. So what are all the possible characteristics? I'm not going to go into the details of it. I'm just going to give you the major ones because he has named his criteria as major and minor as well. And he has told in specific that it need not be necessary. Those 8 things needs to be there. At least 2 major and 2 minor needs to be there. So he has said one is biological plausibility. What does it mean? The association between the two variables should be something which is biologically feasible in nature. Okay. So the biology part of the mechanism, underlying mechanism should be something which you think is feasible. So that is biological plausibility. Next is dose response. That is one increases, the outcome also increases. So I increase the number of smoking butts, my risk for getting cancer should also increase, which again happens, right? And then temporality. So this is one thing which you need to know. That is, the cause should always precede the outcome. That is what he means by temporality. Okay, so that is when I get lung cancer, then I should be a smoker. Okay, so I'm just giving you with this example. So that's how Hill said that at least these 3 criteria need to be present for me to say it is causal in nature. So direct association is something is called as causation, in other words. The next is indirect association. So indirect association is presence of a confounder. I'm pretty sure you've heard of this term called as confounder, right? So when there is another existing variable apart from smoking, which would also contribute to my outcome or influence my smoking, let us say alcohol, for example, then it becomes a potential confounder because the person would have got lung cancer because of alcohol as well as smoking. So then if such a combination is given, then it becomes an indirect association for the variables which is being present as exposures. The last one is spurious. Spurious is something which is not real. Okay, that is 2 variables are present and you are saying that they are associated. But unfortunately, that association is just mere chance, or it is just a random association, or it has occurred by luck, just by coincidence. Okay. So, for example, let us say the most common example which you can see in textbooks is people with the older age. I mean, delivery happening in hospitals, the mortality of the infant is higher when compared to delivery happening at homes. That is one, that. So what does the statement actually mean? It means to say that don't go to the hospital, you can get your baby delivered at home. But that's not true. That's a spurious association, because whenever you are admitted in a hospital, there is a chance that the possible pregnancy has some major complications. So because of which the child's mortality is increased. So there are other factors which has been not been considered, and it is generally with this statement, you're going to conclude that hospital delivery is more dangerous than home delivery, then you're wrong. We know that, right? So such kind of association which just, sprouts out because of some random statements is called as a spurious association. So this was the word which was given to us by our students, the Smoking and Lung Cancer Association. And I thought this could be a possible reason. So they would have asked this statement and said which type of association it could be, which we discussed, or they would have said that the smoking and lung cancer, if it is causal in nature, what could be the criteria you need to see? That is the Hill's criteria, which again we discussed. So these will be the possible ways in which you can, approach this question. So the key word which I think you need to see over here is association is given or causal is given. If it is association, the way you're going to approach is going to be only these three options, nothing more. If it is going to be causation, then you need to think in terms of Hill's criteria as well. Okay, so let's go to the next question. Yeah. So this one is from biostatistics. Okay. So the question again here is direct. You have a two set of mean given, but the data is not normal. So what test you will use? So what I need to look into two parts. First part is, let me give you the options as well. Yeah, first part is two set of mean. So I have got two groups. So I will eliminate ANOVA, I will eliminate Driscoll values, because these two tests will be used only when I have got more than two groups. So I'm left with the two more options, t-test, Mann-Whitney. So the next part of the question, but the data is not normal. So this again is the clue. So which eliminates t-test, and my answer is Mann-Whitney. Okay, so that's how you do it. So you read the question, the key, you locate the key. First key will help you to eliminate major options. The next key will help you to narrow down your answer. So here are two sets of means. So ANOVA is gone. And next clue is it's not normal. So t-test is gone and my answer is Mann-Whitney. So if I'm given this kind of options, first one says two sets of mean. So I'll be left with T or Mann-Whitney. I will remove chi-square and ANOVA, because chi-square is used not for mean, but for proportions. So they have given mean, I will remove it. You are again confused. Okay, mean is given, then could it be ANOVA, t-test or Mann-Whitney, because ANOVA is also for mean. Then you need to look into it. Two said, you don't remember whether it is two is ANOVA or t-test. You have that confusion. You can assure your answer by this part. That is not normal. These two go only if it is normal and parametric test. So my only non-parametric is Mann-Whitney or chi-square. I know chi-square doesn't go with me. So my answer will be Mann-Whitney. Okay, so you understand. So that's how you eliminate your options. Whenever you read a question, always focus for a key. So whenever you read it with a clear mind, don't block yourself. Sometimes, what happens, one major problem I used to face is whenever I do any MCQs, I assume that this is how they've asked, and my mind will try to blur out the important points. So be relaxed, stress-free, read it with the open heart, open your mind, open your eyes and read it so that every question and every word matters to us, because they're going to help us to narrow down to our options. Okay, so then let's go to the last question. Yeah, it's very, very interesting problem solving part. Okay, so I thought I'll just walk it out over here along with you guys. So before that, whenever these kinds of questions are asked, that is, you have an odds ratio or risk ratio, you need to know something called as contingency table, that is the 2x2 table. Okay. So as you can see over here, I'm going to make a 2x2 table. So what should I write over here? Can someone tell me? So what will the 2x2 table headings consist of? Maybe I start, I'll get answers. Okay, I'll make it a little quick. So disease present, What will be here? At least you can help me out. No. Okay, so disease present, disease absent, exposure present, exposure absent. And we will have a total. Okay. And a total here as well. Okay. So what are the numbers which is being seen, or what are the numbers we can see? We have a 24, we have 120, we have a 40, and we have 1,000. Right? So now let us read the question. So whenever you see an odds ratio or risk, relative risk, just put this 2 by 2 table. Okay. So the first sentence, 24 out of 120 lung cancer patients exposed to some drug. Okay. So 24 out of 120. So what is my disease here? It is lung cancer. So how many total people with disease is present? 24 out of 120, right? So it is 120 people with disease. So it's going to be my total of people. So this column is projecting the disease present. So the total people over here is 120. Let me fill that first. So what does this say? 24 out of them are exposed to this drug. So 2S, they have lung cancer, they are exposed. So exposure is also present, outcome is also present. So that is how many? 24 out of them. So let me write 24 over here. So what is going to be this? Left will be 120 minus 24. Right? Yes? Yes or no? So that will be 96. So the next part. So what does this say? People, so next numbers I'm seeing is 40 out of 1,000 exposed to the drug have no lung cancer. Okay. So it means to say that 1,000 is going to be the total number of people in the entire population. Along with that 120 have lung cancer. So this total is going to be 1,000. Right? So 120 are having disease present, that is lung cancer. So the disease absent will be 1,000 minus 120, which will be 80. So in that, people who are exposed but not have lung cancer are 40. So how much is this going to be? 880 minus 40, which is 840. Now let us do the usual one. What we do whenever a question is asked about odds ratio, what will be your answer? We will usually say it is AD by BC, right? Now let us put the ABCD now. Okay, so now I need to do the AD by BC. Yes, here again. So what will be my total? It is 24 plus 40. Which is how much? How much? I suppose this bunch hates max. So it's 64. Oh, yeah, I'm sorry. There are max values. Yeah. Can someone help me with the next calculation then? 96 plus 840. Yeah, very good. Someone's answer. 936. Yes, amazing. So if you want to know whether you're correct, maybe 64 plus 936 amounts to 1,000. So you will know that you have put the numbers right. So now I am going to do this AD by BC, which is seen over here. So this gives me to an answer 5.2. Okay, yes. So what does 5.2 mean? Yes, it means to say OD or the OR is greater than 1. It means to say it is having a harmful effect. You can double confirm it here that my drug that probably that XYZ, if it is smoking or anything which is having a carcinogen, can double confirm it here that this carcinogen is obviously going to cause me cancer. Okay. So this is how you solve any odds ratio or relative risk problems. So first you look at the numbers. Main thing is put the contingency table first. And then whatever numbers you have, you put it that, and then you subtract the other numbers, and then you work out with it. So this is how you will do it. And these were the questions or the probable questions which would have been asked in the INI-CET July 2021. And all these things, like I said, is just from the recall of our students who gave us. So from their memory, we were able to get certain questions, and we have discussed this till now. So the next part of discussion will be on pedodontics, pediatric dentistry by Dr. Padminee. She will take it over from here. You have any queries? You can ask me now, or you can put it in the chat box as well. Maybe at the end of both the sessions, we will go for it. So I would like to stop here. Thank you for your patience, listening, and being interactive as well. Thank you. So I'll give it to the next faculty.
So hi everyone, this is Dr. Padminee. So I'm specialized in pediatric and preventive dentistry. So I will be taking you through the questions that were asked from this specialty in the INI-CET paper 2021. So yeah, just a minute. So July 2021 paper. So just like how Dr. Lakshmi was discussing with you all. So this is based on a recall discussion. So that means the questions that are put up here are not an exact replica of what was given in the question paper. So we will be just discussing around the topic that was asked there. For few of the questions, we do have the full questions along with the options, for which we will be justifying why that particular option is correct. So coming to the weightage distribution, it's around 10 questions that have been asked in pediatric dentistry. And in that, there is an image-based question. So generally, these image-based questions are confusing. And so when you prepare for your pediatric dentistry, you have to also look into the images, because there is a chance, higher probability that you will have an image-based question from pediatric dentistry. And then more importance has been given to development of occlusion and oral habits, particularly the muscular functions. Okay, based on that, I could find a few questions. And from preventive pediatric dentistry, we have one question, and restorative, we have one question, and some miscellaneous questions from the units. Okay, so moving on to the first question. Which of the following is a succedaneous tooth? So this is pretty much a very direct question, I suppose. And I've already highlighted the answer as 1-3, which is nothing but the permanent canine. So can any one of you tell why this is called as a succedaneous tooth? Can you put it up in the chat box? It's a very pretty direct question. Why is the canine called the succedaneous tooth? Here, so when we look at the options, we have a 1-3, which is the permanent canine. We have 5-4, which is the primary molar. 1-6 and 1-7, which are the permanent molars, right? So when we say, yeah, it has a predecessor. Wonderful, thank you. So 1-3 is the only tooth among the option which has a predecessor. So we have to familiarize ourselves with two terms now. One is called the successional teeth. The other teeth are called the accessional teeth. Okay. The teeth which have a predecessor, just like the one we pointed out now, 1-3. So I have added an OPG so that it will be easier for you to follow. So this is a mixed dentition OPG, where you can see there is a primary canine and a tooth bud for the permanent canine. So the primary canine is the predecessor and this is the successor. Whereas when you look at the first and the second molars, they do not have any predecessors. So these teeth are called as the accessional teeth. And whereas those teeth which have predecessors, that is the primary teeth, these are called the succedaneous teeth or the successional teeth. So that is what pretty much we need to discuss here. And it is a very straightforward question, which is going to fetch you a good mark. And then the next question. Okay, function of CPPACP. Okay, what does CPPACP actually stand for? Can anyone give us the full form for CPPACP? What does CPP-ACP stand for? Anyone? That's a pretty easy question, right? CPP-ACP stands for calcium phosphopeptide. Yeah, it's not casein. Okay, it's calcium phosphopeptide and amorphous calcium phosphate. Someone has tried. Thank you. So it's basically nothing but saturated solution of calcium and phosphate. Okay, so this is a little bit tricky question because all the 4 options might seem appropriate because I have already given you the answer. It helps in remineralization, but I want you all to understand why this option is correct, why this option is more appropriate, right? So when you look at it, let's go to the last option, which says it could be a Pitt-Fisher sealant. So we do have Pitt-Fisher sealants based on CPP and ACP. This CPP-ACP is actually a smart material. So there are new developments in the Pitt-Fisher sealants which can release CPP-ACP, right? So that is one option which is actually, it looks suitable. And then when you look at resin-based sealants, again, there are resin-based sealants which are incorporating smart materials, which are incorporating fluoride ions. So again, this could also seem to be an appropriate option and provides fluoride. So there are formulations of CPP-ACP which is also fluoride releasing. So how do we say that option A is correct, right? So when you look at it, CPP-ACP primarily functions by causing remineralization. All the other options are available only in the modification of the material. When you say CPP-ACP, the brand that promotes this material is the GC Mousse. So in GC Mousse, we have 2 types. One is the GC Mousse Plain and the GC Mousse Plus. So whenever the GC Mousse Plus is used, then the role of fluoride comes. So in such cases, the fluoride mechanism is also acting on the tooth. So in this question, the question is only talking about function of CPP-ACP directly. So we need not confuse it with fluoride mechanism or any other sealants. We have to eliminate all the other options because the question clearly states only CPP-ACP, which acts and it helps only in remineralization. So I've just given a brief diagram which will help you understand the mechanism of action. You might not be interested in the theory, but this will actually help you narrow down the options when you attend an MCQ paper. So like I already told you, the CPP-ACP is a smart material. So whenever the pH, the acidic pH is going to fall down, the ACP, okay, the amorphous calcium phosphate is going to release loose molecules of calcium and phosphate that is going to supersaturate the salivary layer around the tooth surface, helping in formation of hydroxyapatite crystals because of the calcium and phosphate ions that are present in excess in the immediate environment. Also, it helps in altering the pH, okay, which is acidic, there is a low pH. It tries to buffer and tries to neutralize the acid attack. These are the 2 primary functions of CPP-ACP, and it is one of the commonly used non-fluoridated remineralizing agent. Okay, so with those things about CPP-ACP in mind, I think option A would be the most appropriate answer. All right, so the next question. Children of 2 to 3 years, they tend to pull food in their mouth and do not swallow. So what could be the probable reason? This is the question that has been asked. Again, among the options, I've already told you, muscles are not able to push the food down. That is the right answer. The other options we have are reflex is not developed. And there is one more option which says they are in the retentive stage and they get the pleasure. So again, we will now justify why the second option is correct. So can anyone tell what this retentive stage is exactly? So it comes under the child psychology. There was one famous psychologist. He's in fact one of the oldest ones who gave the theory which talks about the retentive stage and expulsive stage. Can you tell me which theory talks about this? So that's again an easy question, right? Whenever child psychology questions are asked, we always talk about that theory first. Anyone? Yeah, Sigmund Freud. Yes, exactly. Thank you so much. So Sigmund Freud gave the theory as Sigmund Freud. So Freud's theory is basically based on the fact of the developmental stages. At each stage, there is going to be an erotic zone and erogenous zone, which has to be stimulated for gratification. That's the basic concept. So in that, the second stage, after the oral stage, when the child is of about 2 to 3 years old, that is when they have this retentive and expulsive stage. And this is primarily focusing on the erogenous zone of anus or the urethra. Okay. So it's about the expulsion of the feces or retention of the feces, expulsion of the urine or the retention of the urine. So this doesn't have any role to play with the oral cavity. So according to Freudian theory, the retention in the oral cavity is during the 0 to 18 months of age. The question clearly talks to us about 2 to 3 years of age, but the word retentive can make us, get confused as into, yeah, the 2 to 3 year age group does have some retentive phase. No, it is not connected with the swallowing mechanism. So we eliminate that option. Again, the first option, which says reflux is not developed. No, most of the kids, when they see a transition from the breast milk or the bottle milk, whatever it is, when they see the transition from that to the solid food or the semi-solid food, it all happens during the second or third year of the life. So the age is the key factor in this question. When you look at the age group of 2 to 3 years, most of them would have started solid foods. So it's usually children only when they're up to 6 months, they're exclusively breastfed, after which most of the parents start them on some semi-solid or solid food. So in the 2 to 3 year age group, in fact, most of them would have weaned off and they would be completely on solid food. Once that texture of food becomes completely solid or it is semi-solid, a good swallowing reflex is actually developed in the infants or in the children, right? So there are the second option is now going to be a more appropriate option for us. This is because it is based upon the swallowing mechanism. So what are all the types of swallow we know? When there is a transition, we see there is one kind of swallow when the children are very young infants, and then when they enter into childhood, the swallow mechanism changes because of the texture of food. What are the different types of swallow we can see in children in the pediatric age group? Can anyone put me? Yeah, there is an infantile swallow. Very good. There's an infantile swallow and there is a mature swallow. And we also have something called as the transitional swallow. When they change from the suckling mechanism that after the breast milk, from a suckling mechanism, they tend to chew food and eat when the teeth erupt, right? So there is a transitional swallow that is seen. And we have a good mature swallow when they once grow up. See, after if there is going to be any retained habits of thrusting, tongue thrusting, there is no proper oral seal that is created, then we have a thrust swallow, which can be a simple thrust swallow or a complex thrust swallow. So from what I've discussed now, we can actually get 5 types of swallow. All right. So the one would be an infantile swallow. Then we have a transitional swallow. Then we have a mature swallow. And if there is going to be any retained habits, that is, we generally call it a retained infantile swallow. Among the retained infantile swallow, we have something called a simple thrusting swallow and a complex thrusting swallow. So when you look at the different types of swallow, you will know that the muscles play a very, very important role in pushing down the food into the oral cavity, right? So in an infantile swallow, the tongue plays the primary role along with the lips. So the lips should seal around the breast and the tongue should form a very good trough so that it can press the nipple against the palate and it can create the peristaltic movement, which can, make the milk be delivered into the oropharynx directly. So that's how it works in an infantile swallow. When there is going to be a transitional swallow, you can actually see that the mandibular movements decrease. And the tongue is trying to interact only with the palate and not the lips, and more of a mature swallow is seen. So in a mature swallow, there is completely no involvement of the lips or the mandible. It is only the tongue and the palate that plays a major role. So when any of these muscles are weak, if the tongue muscle is going to be weak, or if there is going to be a hypertonic lower lip or an upper lip that is going to get involved with the swallowing process, and in that cases, you can see the child will be more of a messy eater. They'll be dribbling the food. They'll not be able to take one whole bolus of food at a time. So the muscles play a very, very important role in the swallowing mechanism. So that is exactly why this option is right. So muscles are not able to push the food down in a 2 to 3 year old age. In such cases, they try to pouch the food on one side. Okay, that is why they try to pull the food. That is what the question says. So this pouching the food, what it does? They take more time so that the food can actually become more soft inside the saliva and they can easily swallow it, right? So pouching the food and they do not swallow it easily. All these things are an indication that there is a muscle weakness in the orofacial region, right? So the next question, over time, which of the following has the best has been the best, okay, in improving oral health of the pediatric patients? So this question is not a direct lift from any of the textbooks, or it's not a factual question. The options here are also again confusing. So it says free giveaway reading materials, or chair-side motivation of the parents, or psychological counseling. Okay, so these three options are also again overlapping and confusing. Most of the times we would feel it is a combination of all these three that works out. You know, a child walks into a clinic, we try to, you know, provide them from some educational information in the form of brochures, and then we try to talk to the parents and explain how basic oral hygiene is important, and we also try to talk to the child, do some psychological counseling with them. So this is always a combination of all the three. So how to choose the best answer? So this particular answer is based on my experience. I do not have a solid concrete evidence supporting it, but I can probably give you additional information as into why I have chosen this option could be correct, right? So basically, I'll recommend all of you to go through AAPD's guidelines. Okay, when it comes to pediatric dentistry, the American Association of Pediatric Dentistry's policy documents are the like the Bible for us. Okay, we always follow the AAPD documents for any policy guidelines or clinical guidelines. So when you look into the AAPD document for non-pharmacological behavior management or behavior management in children as such. So when you look into the recent guidelines, 2020 guidelines, it is all the behavior management techniques are conglomerated into one particular document. In that, we have something called motivational interviewing of the parents. Okay. So I'm just going to put in some more information about motivational interviewing. So this motivational interviewing is basically consists of four aspects. One is you ask open-ended questions to the parents, and then you give them affirmations. You give them positive reinforcements about how they have to bring a behavioral change in developing good oral hygiene practices for the children. Then you see reflections, the way they receive the information. And finally, you summarize the entire content to the parents. This is how the motivational interviewing works. Okay, so AAPD recommends motivational interviewing as a very effective, mechanism to improve the oral health in the pediatric patients. So when it comes to pediatric patients, maintaining the oral health does not solely depend upon the child alone. Okay, the parent has an important role to play so that the child can develop healthy oral hygiene practices like brushing twice daily and using mouthwashes if required, flossing if they do not have a spaced dentition. So all these things would require assistance, and it will also require a lot of motivation from the parents' side. Okay, so based on the AAPD documents, content, and how it gives importance to motivational interviewing, I think choosing chair-side motivation for parents would be the best option for this particular question. I think we are all on the same page. Do you have any clarification with respect to this question or any difference of opinion? You can actually put it in the chat box. All right. So I'll be moving on to the next question, but you can still discuss about any of the questions that has been previously discussed also. Then there is this question. So this was one incomplete question, muscle in mouth breathing. Okay, so for this question, there was no proper question that was formed, nor there were options given. So I've just discussed about what are all the muscles that are involved in mouth breathing, and how it is important clinically to identify if a child is having mouth breathing habit. All right. So I have listed down the features here. I will just take you through each feature. So basically, when you look at this picture, a child who's been chronically mouth breathing will have very tired eyes, will have a crooked nose, will have a receding chin, and will have a smaller airway, and there will be some amount of posture, a different posture will be there. So can any one of you tell why all of these are happening? We will go one by one. Why the child will have a tired eyes? When a chronic mouth breather, you can easily find them, they feel tired all the day. They have very tired eyes. Anybody can give me a probable reason as to why mouth breathing is affecting, dehydration? Yes, is one aspect. There's one important thing every person would need. If that gets affected, you feel tired all the day. Dehydration is very good answer, because there's going to be a lot of dryness in the world. Yeah, lack of sleep, very, very important. A chronic mouth breather will not be having a good quality sleep. Lack of sleep is actually leading to the tired eyes of the child. Okay, so they're not able to have good attention, and there will be a lot of sleeping issues. When they try to sleep, they try to sleep on the tummy, or they try to do a 360-degree turn in the bed. They try to sleep in different positions. They keep changing positions. They generally lack a good quality REM sleep, which is very, very important for a person. And that is what we see in chronic mouth breathers. Then there is a second feature which says crooked nose. So this can have an anatomic reason and a functional reason. Can you tell why the nose gets crooked? So how does this happen in mouth breathing? Any guesses? Or it's actually basically very logical. It's like a domino effect. When the child starts to breathe through the mouth, one after the other gets affected. So there's a crooked nose and a receded chin. Both of these are attributed to it's actually the same reason which causes crooked nose and the receding chin. Any answers? Okay, right. So basically what happens in mouth breathing is the upper jaw is generally anatomically, it can be small, or functionally if the tongue is not functioning properly. If there is going to be an associated tongue thrusting or a macroglossia, okay, the tongue is not able to rest in its normal position. When the posture of the tongue is not proper, if it's not able to rest on the palate, ultimately the jaw growth does not happen. Okay, so when the maxillary growth does not happen, the palatal vault, it becomes more dome shaped, it's more narrow arched. Okay, so what is happening here is the roof of the mouth is actually the floor of the nasal cavity, right? So when the palate is going to be more dome shaped, your nasal cavity space is going to reduce down. So that is what is actually causing the crooked nose. And when there is no maxillary growth, so it's the counterpart principle here. Only when maxilla grows, the mandible is also going to grow, right? So there is a maxillary constriction. The mandible doesn't grow when you have a receded chin. Okay, so this is the domino effect I was talking about. The tongue is not having a proper posture, causing doming shape of the palate, which leads to crooked nose and receding chin. And constantly they try to breathe through the mouth, and leading to a lot of, when the air goes through the nose, there is a filter, right? So there's not going to be much of infections. When they actually breathe through the oral cavity, there is no filter, and therefore you have a lot of tonsillitis cases, adenoid cases, and because of the chronic inflammation that is there inside the mouth, there's going to be a smaller airway, and the body's primary function is to breathe. So what is the body going to do? It is going to try change the posture so that they can have better breathing habit. So it's all interconnected to one another. That's what this picture comprehensively explains about what actually happens. So this is what is the clinical features that we are going to see in a mouth breathing case. And also, based on these clinical features, we can understand easily how the muscular actions are, changed. So look at the list I have given. So you have hypotonic upper lips. So basically, mouth breathing happens when the lip seal is not effective. Okay. So when the lip seal is not effective, the upper lip is going to be hypotonic. That is, the upper lip is not able to come down, do its action and create the lip seal. Whereas the lower lip is going to be hypertonic. Okay. When the upper lip is incompetent, the lower lip tries to compensate for it, right? So it tries to go up and close. Okay. That's what it tries to do. So we have a very hypertonic lower lip, which is easily identifiable. When you look at the person's face, there will be puckering of the chin. You'll have something like this. If you can see my face, you'll have some very constricted, lot of crease lines on the chin, which is called puckering. And when you look at it from the profile aspect, it will look like a football. So it is called as the football chin or the puckering chin. So the labial muscles are primarily affected in mouth breathing. Okay. After which you have an associated tongue thrusting habit. Usually all mouth breathers will have a tongue thrusting habit, because there will be an open bite, there will be a narrow maxillary arch, and they will always thrust their tongue to the anterior teeth. It will mostly be an anterior thrust. Very rarely we get a posterior thrust. So there will be an anterior thrusting of the tongue. The tongue is the next muscle that gets affected in mouth breathing. And if you want to even go deeper and assess the muscular tonicity of the other facial muscles, you will find there is an altered tonicity of the buccinator, the cheek muscles, and the orbicularis oris in total, right? So these almost all the muscles get affected, but the primarily the daring clinical feature is with the lips and the tongue. Okay, these are the most commonly involved muscles in mouth breathing. We'll move on to the next question. So this is again a pretty straightforward question. Okay, mixed dentition OPG. In a mixed dentition OPG, which tooth has no succedaneous tooth? So I just need you to put out the answers here. There was no options given, and I thought it was a pretty straight question. Can I have the answers? Permanent molars, yes, excellent. So only if the child is 6 years of age, I could say it is permanent molars. What if it is a 7 or 8 year old's OPG? If it's a 7-year or an 8-year-old child's OPG, there will be other teeth which do not have successors, right? Do you understand my question? So permanent molars are right. It's a very straightforward answer. They don't have any predecessors. And I already discussed what are accessional teeth. They are accessional teeth. What if it's a 7-year or it is an 8-year-old's radiograph that we are looking at? We will still have some teeth which doesn't have a successor, right? So I think it's an easy question. If you know about the eruption chronology, you'll be able to answer this this part of the question. Which tooth erupts around the age of 7 or 8 years? No answers. So eruption chronology is like the basics of pediatric dentistry, right? Or it's the basic for any dentist to know. Which teeth erupts around the age of 7 or 8 years? Come on, you answered all the difficult questions. This is a very, lateral incisors at 8 years. Lateral incisors come at 8 years, 7 years. It's an age range, right? For your central incisors. Yes, it's the central incisors. So the around 7 to, maxillary central incisors, they come at around 7 to 8 years of age. At that time, you also have the lower incisors would have already erupted around 6 years of age. So if because this question here, I have put a very direct OPG. We don't know in the INI-CET paper if they had an image to this question. If there was an image which showed you an 8-year-old OPG, you would have incisors that don't have succedaneous tooth there. So in such cases, you shouldn't get confused. That is why I was trying to raise this point. The answer is permanent molar, whichever age it is, because molars are the accessional tooth. All right. So in the mixed dentition, when we say mixed dentition, from 6 years, we consider it to be mixed dentition. The first cuspal eruption we see, the molar area, at that stage itself, we call it a mixed dentition phase. Okay. So the molars are the right answer, whatever age group it is. But if it is going to be an 8-year-old radiograph where you do see teeth without successors, it is because they are all succedaneous tooth. They were succedaneous tooth, right? Because they all had a predecessor. So I just wanted to ensure that you are on the right track. That's all. And then the other question, this is a picture-based question. So the question that was given to me said the paper had a picture of a Gropper appliance. I don't know if you people know what a Gropper appliance is. Does anyone know? Okay, I think someone has asked about the previous question. No permanent tooth has their successors, right? Yeah, no permanent tooth have their successors. That is what I wanted to bring to notice. You just need, but some of the permanent tooths are named as successional teeth. So the terminology is what matters. That is what they're expecting you to answer, right? So a central incisor definitely would not have a successor, permanent central incisor, but it is called a successional tooth because it had a predecessor. So molars are the clear-cut right answer. I was just trying to confuse you to see if you're all understanding the concept. Okay. Someone has raised hand. You have something to say? Can you put it in the chat box? Is there a confusion with the previous question? So if you have any queries, you can put it in the chat box. I think someone has raised a hand. You just put it in the chat box. I'll just continue. Yeah, sorry. So this is the image-based question which talks about the Gropper's appliance. Anybody has an idea on as into what a Gropper's appliance is? You can, see the image and also guess. What do they look like? How are they looking like? Anyone knows what a Gropper's appliance is? What is it otherwise called? What is it primarily used for? Any idea? Something based on the image you can guess. It looks like artificial teeth are being placed there. Any guesses? All right, I'll just educate you on this. So it's basically indicated in children at least 3 years of age, or at least after the second primary molars erupt. That is when the Gropper's appliance are indicated. And in these children, if the anterior teeth is, I have an answer, I guess. Prosthetic management with ECC. Yes, that is a very good answer. So it's basically, it also comes under a prosthetic management. We can also call it as a functional space maintainer. Okay. So what happens is the anterior teeth, when they are lost due to ECC, or when the crown structure is completely destroyed and we try to retain the root stumps alone, in such cases, for the purpose of aesthetics and for the purpose of function, we try to give the Gropper's appliance, where the banding is done in the second primary molars. And I think you all would be familiar with the Nance palatal appliance. So the wire construction is very similar to the Nance palatal appliance, and we have an acrylic component containing the teeth, or we have metal cleats to which the teeth pontic is being actually attached. And the teeth are generally, made up of only acrylic, heat cure or cold cure, based on the, preference. So it's given even if one single incisor is missing, or if all the 4 incisors are missing, it is just an aesthetic replacement, and it also helps in phonetics. Otherwise, the parents do fear that the child might develop a tongue thrusting habit, but usually the tongue thrusting habit will be a transitional one. It will go off once the central incisor comes. But if the parents are worried, we do suggest them with the Gropper's appliance, and it also plays a very important role in aesthetics. The child doesn't feel bad that it does not have the front teeth, right? So once the child turns 3 years, and if it is actually unfortunately suffering from ECC, then we can put them on the Gropper's appliance. It is also known as the Hollywood bridge. Okay, so that's the alternate name given to it. Probably if the options are going to say a Hollywood bridge instead of Gropper appliance, you need to know that it means the same. Okay, then we'll move on to the next question. Seizures in children. This was again an open-ended question. I did not know what was actually asked under this, and there were no options. So I thought of 2 possible questions that could have come. One is the common type of seizures that you see in children. The other one could be on the behavioral management aspect, if this question was considered under pediatric dentistry. Probably this can be also asked under general medicine or oral pathology or oral medicine. But if you take this question up under pediatric dentistry, these are the 2 common things I thought could have been asked. So when you look at the types of seizures, we generally classify them under 6 different types. Now the common type is called the absence seizures, which is very common in children. Okay, it's the absence seizures. And one more type of seizure is the febrile seizure. So the febrile seizure is more of a symptomatic expression. When the body temperatures go very high, the child might experience seizure. There might not be any other organic cause, but in these 6 types of seizures, you might find an organic cause with respect to any brain infection or a meningitis or something that might be related to it. And among that, we have the absence seizures to be more common. But I think I'll concentrate on this part that will be more relevant under pediatric dentistry, behavior management of a child having seizures. So basically, the principles are all same. Okay, you need to fix an appointment at a time which is convenient for the child. And then you should know what medications they are on. These are all the basic principles. I've just pointed out 2 things which are considered to be a recent aspect. So just like I already indicated to you, you people should go through the AAPD's behavior management document. Okay, that's like the most comprehensive document you can find on behavior management. There are good textbooks which you can refer to, but that might be of a postgraduate level. So to attend a competitive exam, I think an AAPD document should be more than enough. So when you look into the document, you have something called the sensory adapted dental environment, which actually makes the dental environment environment more friendly for a child, a special child, particularly who's medically compromised or who's physically compromised. You can help them with creating an environment where the lighting is not too bright that is going to trigger seizures for them, or you can put them on a pleasant music which is going to act as good audio analgesia, or which is going to act as a good form of distraction. The basic concept of developing a dental environment that is adapted, that is addressing to the various sensory needs of the child, is the recent trend that the AAPG has suggested for special children. Also, there's something called the snow zelen room, which might be new to you, because the snow zelen room is completely based on the sensory adapted dental environment. This was primarily developed for kids with autism or any mental disorder, but these rooms are also proving beneficial for children with medical complications like seizure, cerebral palsy, all those things. So this is something that you need to look into, familiarize yourselves with this, so that if a question comes under this topic, you can probably attempt it well. So we come to the next aspect, which is a child with diabetes or thyroid issues. So after extraction, bleeding doesn't stop. What could be the possible reason? So I've listed out few reasons. So what is the basic issue with diabetes and thyroid? So I think you'll all have a basic knowledge about what diabetes is. Anyone? Few words, single word. So yeah, I think we are running out of time. So it's basically nothing but poor glycemic control, high blood glucose. Yeah, thank you so much. So that's basically poor glycemic control. And with thyroid, we have two types. It's either hypothyroidism or hyperthyroidism based on the levels of TSH and T3 and T4. So, but when it is with diabetes, you have to look into the question again. It's usually hypothyroidism that sets in when a patient is having diabetes. So diabetes and hypothyroidism generally go hand in hand. So when they say thyroid issues, you need not get confused with hyperthyroidism. It will be generally hypothyroidism that we see along with diabetes. So the Q is diabetes, which tells us the thyroid issue will be a hypothyroidism. So extraction for a child is suffering from these two conditions. So when you look into the thyroid levels, somewhere it actually helps in the clotting process. Thyroid plays an important role in various metabolic processes, growth, everything. So when you look into the clotting mechanism, it tends to cause a lot of fibrinolysis, and therefore the coagulation process is very less in a thyroid patient. In fact, one of the chief complaints could be easy bruising. They will have multiple bruises in the body with no actual cause. Okay, in such cases, you can actually suspect hypothyroidism. In fact, in adult, elderly women, menorrhagia is a very, very common effect of hypothyroidism. So that is related to this particular aspect, because after extraction, a good mature clot is important for the healing to occur. With hypothyroidism, the clot never forms. And with diabetes, even if the clot is going to form, it is not going to mature at all. Okay, because of the high glucose levels, there is going to be a lot of microcirculatory deficiency, causing thickening of the basement membranes of the capillaries, which are important, to migrate the leukocytes. The leukocytes need to regress, they need to cause the clot regression, and epithelialization should happen. I think you would all be familiar of how a socket healing happens, right? So in diabetes, you have a delayed wound healing, and with thyroid, you don't have the clot being formed properly. So these are the two basic reasons which will attribute to the bleeding that occurs post-extraction. So you need to obviously take precautions when treating such children. And that is pretty much about this question. And with that, I think we move to the last question. So so this was about the proximal caries restoration treatment. I don't know if this was asked as a part of operative dentistry. If the question, because this was again an open-ended question, I did not get the complete question. So the question actually says proximal caries restoration treatment. So I just listed down some of the available options for a primary tooth. So when you look into it, all these comes under minimal intervention dentistry. You have something called the tunnel preparation, slot preparation, mini box preparation. These are some of the techniques that have been proposed. Apart from the traditional class 2 restorations, which are no longer used, no longer recommended by AAPD, we do not do any traditional class 2 restorations in a primary tooth. So it's either a tunnel, slot, or a mini box preparation based on the extent of the caries. So that is what this image is about. And the Hall technique, which is again over the last decade, it has taken a great, it has caused a great shift in the paradigm, I would say, in the treatment paradigm. Proximal lesions treated using Hall's technique have the best outcome. Okay, so it can be the Hall's technique where you don't touch the tooth at all, or it's the stainless steel crown, or the direct crown, which is placed after the minimal tooth preparation is done. So it's basically based on the clinical judgment of the operator. And I've also added SDF here because, again, recent guidelines from the AAPD based on the caries risk management, it does advise the use of SDF, 38% SDF for a lot of class 2 lesions. But when you look into the question again, it says restoration. So when you talk about restoration of fluoride protection does not come under restoration. This is just additional information for you. Okay, so but you can call Hall technique and SSE as restorations because these are generally termed as full coverage restorations. So these can also be termed as restorations. That is what I wanted to bring to your notice. I think that is all we have to discuss about these questions. And yes, I think we are done with the questions that have been asked in INI-CET. And we are open to questions from both public health aspect and pediatric dentistry aspect. So both of us are available to answer your queries. You can drop in your questions in the chat box.
If there are no questions, then we can wrap up the session. Which child is not able to swallow it?
Yeah, okay. So this is regarding that swallow mechanism, which was I was talking about. What is the treatment for the condition in which the child is not able to swallow due to a weak muscle? This is what we call as an immature swallow or a retained infantile swallow. So we need to basically identify the cause, right? So when I say the cause, it could be the tongue function that is being restricted here. The child might have developed a tongue thrusting habit. Okay, if it is a tongue thrusting habit, then we do have options like the reminder therapy, where we use the tongue crib or the hair aids, all of which will help train the tongue and remind the child that putting the tongue forward is not going to help her swallow, help him or her swallow. That is one aspect if the tongue is involved. If there is weakness of the lip muscles, we do have a lot of lip exercises that can actually be used. So the lip exercises would be basically pulling the upper lip over the lower lip, or it will be using some buttons which can be tied to a thread, and the button is placed inside and held with the lip seal, and the child is asked to pull out the button. You can use a paper and ask them to hold it between the lips for some time. So if you want to read more about this, you can refer to Nikhil Marwa. There's a tabular column in that. Where various exercises are given. Even the newest edition of Shobha Tandon has a good compilation of all this. There is a paper on oral gymnastics. Okay, so the paper on oral gymnastics, you can Google it. It's a very nice compilation of all the muscular exercises that a child can do and slowly tone their muscles and get a good swallow. Okay, you also have some appliances that the MyoBrace systems have introduced that can also help them in train the muscle. So you can probably refer to the article on oral gymnastics. Any other question? I think I've answered your question. If you still have doubt, you can put it in the chat box. Any other queries?
Sir, I think we are done from our side. So are there any closing remarks or?
Okay, so we would like to thank the organizers for giving this opportunity. It was actually a nice session to revise all these questions with you. I hope it was all useful for you, and my best wishes for all of you to be, to grow high in your lives. Thank you.
Thank you from my end. Thank you everyone for your patient listening. So it was a new experience for both of us, and hope it was beneficial to everyone over there. Thank you. Have a great week ahead, everyone.